Our next subject is adrenal hormones. Remember, this is your fight or flight mechanism. So let us talk about what this means. This is potassium sodium regulation with aldosterone. Also, this is cortisol, your stress hormone. Chronic stress, we know, depletes serotonin. Chronic stress also raises cortisol levels. So I'm not saying that anybody in this class necessarily, I'm just saying in general. If we were to do cortisol levels on, say, nursing students, we'd probably find that your cortisol levels are up, serotonin levels are down. Cortisol does the metabolic regulation. When you see those commercials that talk about the abdominal fat that deposits adipose centrally, that's what they're really saying there. Has anti-inflammatory effects. It maintains behavior and cognitive functions. So I want you to think about the way you feel right before a test and tell me how many of those in general you think apply to you that you have noticed a change with. Okay, hyperadrenal diseases are going to be hyperaldosteronism, also known as Conn syndrome, and pheochromocytoma. Hypofunction is Addison's and adrenal crisis, and they need more cortisol and aldosterone than is available. So with Addison's disease, you are likely to see some increased pigmentation. Remember, melanocyte-stimulating hormone. If it's autoimmune, they may have decreased melanocytes and pigmentation. And this is a good quick picture for you to remember Addison's disease. And the best example I can think of is George Hamilton. You know, that kind of orange glow? Hypoglycemic, postural hypotension, weight loss, GI upset, weakness, changes in the distribution of the body hair. Adrenal crisis may include profound fatigue, dehydration, vascular collapse, renal shutdown, a drop in sodium, and increase in potassium. So these people are a hot mess. What are you going to do about those things that we just talked about? Promote fluid balance and monitor for fluid deficit, daily weights, try to make sure that we're keeping track and helping them, remind them about their fluid balance. We're going to watch vital signs every 1 to 4 hours, looking for dysrhythmias or postural hypotension. Monitor lab values to catch those early HEMA concentrations. Give cortisol and aldosterone replacement therapy. Watch sodium and potassium. And when we put them on glucocorticoids, because their body wasn't producing enough, think prednisone, we're going to need to come off of those slowly so that those adrenal glands have a chance to start working again. Once they're out of commission for a while, it takes more and more to get them back up to speed. Hypercortisolism. Cushing's disease is due to a pituitary source. Cushing's syndrome is an ectopic or adrenal source. So if it's coming from within the brain, our master gland, then it's disease. If it's coming from the adrenal glands themselves sitting on top of the kidneys or an outside reason, it's called Cushing's syndrome. There's another type called iatrogenic Cushing's, which is from the overuse of corticosteroids. Remember I said a few minutes ago that if we have somebody on steroids for a length of time, those adrenal glands take a while to kick back up and run. Well, they get really confused. They don't understand when somebody tries to help them. Okay, here's a good one. Think of your adrenal glands as your 2-year-old saying, I do, I do. So they're trying to take over, and sometimes they do too good of a job, and sometimes they don't do good enough a job. So what are are we looking for as far as assessment pieces with Cushing's of any sort? The striae are very common. Their skin becomes incredibly delicate. The abdominal distribution of adipose. The buffalo hump is characteristic of Cushing's. Think of the adrenal gland hyperfunction as the same symptoms you would see in somebody who is taking prednisone for an extended period of time. And you'll have a picture of what this patient would look like. Non-surgical management is going to include daily weights, fluid restriction, drug therapy for temporary relief, and radiation therapy for adenomas. So this is the overstimulation, and this is what you see. Personality changes. If you've ever known anybody who's taken prednisone, you will remember that they tend to get a little aggressive. Moon face, that rounding out, increased susceptibility to infection. Males may have some gynecomastia, fat deposits on the back, may develop osteoporosis over time, bruises and petechiae, purple striae, thin skin. Females may have amenorrhea or hirsutism. Hirsutism is the male pattern facial hair on a female. GI distress because of increased acid. The thin extremities, sodium and fluid retention, may have some CNS irritability and hyperglycemia. Pheochromocytomas are interesting little bugs. They are tumors that tend to be on the adrenal glands, may happen in the abdomen, but they release catecholamines. So it increases the epi and norepi and increases the sympathetic nervous system. So your body really thinks it's fight or flight, fight all the time. So you can see these with genetic disorders, neurofibromatosis, rarely with multiple endocrine neoplasia. More often it's females than males, age range is 40 to 60. Intermittent episodes of hypertension or attacks, varying in length from a few minutes to several hours, may have nausea, vomiting, profuse diuresis, apprehension, and chest or abdominal pain. So if we have a tumor, what are we going to do? Take it out. Main treatment is surgery. But first we're going to manage that hypertension. And because their body is in fight or flight mode all the time, we need to give them a very rich diet as far as calories, vitamins, minerals. They need all the support they can get. So they may do an adrenalectomy. They're going to start on hypertension meds a couple of weeks before surgery, but not beta blockers until after the alpha-adrenergic blockers have gone into effect, because we may actually cause rebound hypertension if we do that. We can use the beta blockers for tachycardia or dysrhythmia. If it's inoperable, we can stick to alpha and beta blockers. We're not going to touch chemo and radiation. So postoperatively, we're going to replace any hormones or steroids that are missing, monitor vital signs, input-output, and watch their blood pressure carefully when they're on opioids. Prevent skin breakdown, watch for hypotension, hypovolemic or hemorrhagic shock, pathologic fractures, because remember their calcium level, and GI bleeding. If at the same time they've done a hypophysectomy, the interventions are the same as for both of them. It's just all put together for you, okay? Hyperaldosterone. Symptoms may include headache, fatigue, muscle weakness, nocturia, peeing at night, polydipsia, polyuria, paresthesis of decreased potassium level. So what are we going to do? We're going to give drugs to increase potassium level. Spironolactone is a diuretic, but it's actually hormone-based, and if they can't do surgery, they can do spironolactone for fluid electrolyte imbalance. Surgery only when the potassium levels are normal, and they need a medical alert bracelet. glucocorticoid replacement to prevent adrenal crisis. And you can refer back to the adrenal crisis section to see what we were talking about there and what we need to be watching for. Parathyroid. These buggers control our calcium and phosphate. So our ultimate goal, if our parathyroids have gone crazy, means that our calcium levels are up, which means it's coming out of the bone. Remember, there's that inverse relationship between calcium and phosphate, so calcium levels go up, phosphate levels go down. Non-surgical management, diuretic and fluid therapy. It can also do drug therapy, calcitonin, calcium chelators, digitalis, phosphates. Medical management is going to include lowering the elevated calcium levels and using anti-resorption agents. Some of the primary great nursing diagnoses will include impaired urinary elimination and constipation, imbalanced nutrition less than body requirements, and risk for injury. Think about what we were talking about earlier. With calcium, if the calcium level is off, we worry about keeping them safe. So, if a parathyroidectomy is done preoperatively, we need them to be stable before we do anything. Calcium levels have to be in normal range. We're going to do bleeding and clotting time studies in a CBC because calcium is going to affect bleeding and clotting. You can teach coughing, deep breathing, and neck support. Postoperatively, we're going to watch for respiratory distress. Keep emergency equipment like a trach kit at the bedside, because hypocalcemic crisis can occur. If this person has a parathyroidectomy and goes into hypocalcemic crisis, think tetany and seizures, and it can affect the larynx. We need to make sure that we can keep this person breathing. Recurrent laryngeal nerve damage can occur. Now, let's say, for example, iatrogenic. We caused it when we were fixing something else. So they went to remove part of a thyroid and oops, got the parathyroids. That would be iatrogenic. So we're not getting enough action from the parathyroid. Hypomagnesium. So what are the interventions going to be? Fix the calcium, vitamin D, and magnesium levels. Laryngeal spasm, we want to make sure that we can keep this person breathing. And again, risk for injury because of the tetany. Special points with endocrine as far as assessment goes. You want to ask about any changes in energy levels that would tip you to thyroid or adrenal problems. Elimination, are they urinating the same? Are they able to have regular bowel movements? Has anything changed? Sexual and reproductive functions, menstrual or libido changes. Have they had any changes in their hat, glove, or ring size? And look for the following. The prominent forehead or jaw would tip you to acromegaly. The round or puffy face, think adrenal glands. Dull or flat expression, exophthalmos. Vitiligo, or that bronze coloring that you see with Addison's. Striae and hirsutism. Mostly, we're out of luck when it comes to assessing endocrine tissue, endocrine glands. Most of them are going to be buried deep. The only ones that we can really get to are the thyroid and the testes, and they're not ones that are going to cause immediate severe damage. So, just a thought, knowing the right questions to ask is going to be very important. That's going to be what tips you off to what's really going on with this person. And we can do stimulation suppression tests, assays, urine tests. We can test for glucose, x-ray. If we're talking about altered calcium levels, we're probably going to be talking about altered bone density. And so the risk for fracture goes up. Just an FYI, these are the things that we need in order to accurately assess an endocrine system. So if the suspicion is that something's going on with the thyroid, palpating it is nice and everything, but it doesn't tell you a lot except whether or not it's the same size you expected it would be. And this is the end of endocrine. Now, wake up, go fill out your endocrine worksheet, and have a good day.